And so welcome to part 3 of the Cognition Primary Care series. My name again is Brock Gaster. I'm the director of the Cognition Primary Care program, a primary care doctor at the UW Medical Center at Roosevelt, and have become a primary care and a dementia expert over the last 7 years, and am really happy to be joined today by my colleague, Dr. Jacqueline Reitz.
Hi there, I'm Jackie Reitz. I am an associate professor in the Department of Family Medicine and one of the associate program directors for the Family Medicine residency here at the University of Washington. I have a geriatrics fellowship background, and in addition to teaching family medicine, teach geriatrics, do a little nursing home work, and work at inpatient palliative care at Montlake.
All right, and so neither Jackie or I have any financial disclosures to tell you about. And so this is the last and final part of this 3-part series on cognition primary care. Today we're going to be talking about managing dementia as it progresses. Before we do that, let's do just a really quick recap of the previous session, which, as you'll remember, was setting a plan for the newly diagnosed patient. And so the two most important take-home points from the last session were that if somebody is presenting with cognitive impairment and visual hallucinations, it's very important to refer them much sooner to a specialist, because they really do need workup for a less common cause of dementia, which is Lewy body disease, which has important practical care issues. And then you really can make a difference that by encouraging people to reduce their alcohol intake, encouraging them to wear hearing aids, by treating sleep apnea, by having them stop potentially harmful medications like zolpidem, that you really can improve their cognition. And all of this is in our Cognition Smart Set to give you a great checklist reminder. So let's go back to the case that we have been following along for all 3 parts of this series. You'll remember this was an 82-year-old woman who you diagnosed with mild cognitive impairment. And after a discuss the diagnosis visit, you had a set a plan visit, and she agreed to reduce her alcohol intake and wear her hearing aids more often. And she did tell you that, yes, that did really seem to help her cognition. And she now returns to see you 1 year later. You repeat her MOCA, and it's now 21, so really close to what it was before, down a little bit. But her husband, who you're now very, very helpfully having come to every one of her visits with her, is really starting to notice that she's now needing to need some help with activities of daily living, such as cooking and cleaning. And so you're now ready to shift her diagnosis from mild cognitive impairment to mild dementia. So learning objectives today are going to be, we're going to be covering medications to treat cognitive decline. We're going to be talking about the management of agitation and other behavioral symptoms of dementia. We're going to talk about communication tips for talking to someone with dementia. And then we're going to end with just such the important final topic, which is advanced care planning specifically tailored for dementia. And so let's start talking about the medications that have been FDA approved for a while now. Donepezil and memantine are the 2 most commonly used ones. The most important take-home message about these 2 medications is that they do not change the trajectory of the disease. So these are not the disease-modifying agents that a lot of people are spending a lot of money to try to find, and are maybe making some progress, but we're not there yet. But and they really do not work for early stage impairment. So for mild cognitive impairment, like our patient was when we first diagnosed her, these medications have been tested really carefully versus placebo to see if they make any difference in somebody with mild cognitive impairment, and they have not been shown to be better than placebo in that setting. They are a little bit effective in people who have dementia. They can give result in a small improvement in some people, so they can slow the loss of function a little bit in some people, not in everybody. So it's absolutely reasonable to eventually offer one of these medications, as they are safe, they're very easy to prescribe. But do keep in mind that these are symptomatic medications. They're not neuroprotective, and really much higher priorities are encouraging people to wear hearing aids, treating sleep apnea, and reducing alcohol intake. And so getting in a little bit more into detail about these two medicines, they are very safe, but they can cause side effects. So it is not uncommon for people to have some diarrhea or some nausea. People also sometimes report having really unusual, strange dreams from these medicines. But it is perfectly reasonable to try them. And it's actually, if somebody isn't experiencing mild symptoms like this at the beginning of treatment, you can encourage them to stick with it for a little bit longer, because sometimes those symptoms, those side effects do wear off. And you can potentially reduce the dose if side effects occur if you have increased the dose, but really have a low threshold to stop if these medicines seem to be causing some harm, and especially if the patient and or family are not really sure that they have made much of a difference. It's also really so totally solid and appropriate to stop these medications once dementia progresses to especially very severe stages. Donepezil especially is less effective in very advanced stages. Memantine is the medicine of the two that has been studied in more severe disease, but really its efficacy is not demonstrably different than donepezil, and the two are sometimes combined, but there's really not great efficacy data for using them in combination. Now let's talk about the newest drug that's been FDA approved for Alzheimer's disease, which is aducanumab, which is a monoclonal antibody against amyloid plaque that, in a very controversial move, the FDA did approve it in 2021. It was it was a very controversial decision, and so CMS Medicare really was put into a very difficult position of this medicine that was did not really show to be all that effective, but was extremely, extremely expensive. And so CMS Medicare actually made the decision to limit paying for this medication only for patients who are enrolled in a clinical trial, because it is an incredibly expensive medicine. And really, the rationale that CMS Medicare came up for that is that the efficacy of aducanumab is very controversial. It's very unclear how much true clinical benefit there is from this medicine, which is actually why the scientific advisory panel to the FDA actually voted 10-0 against approving it. And so the fact that FDA did end up approving it against the advice of its scientific advisory panel was very surprising to many. It's a once-a-month IV infusion that is generally given for many years, and it does cause potential harm. So there is risk of brain edema and bleeding from aducanumab. And so this is not the blockbuster medicine that everyone was wondering if it might be. But it is probably one of many drugs like this that will come up for FDA approval in the coming years, and we're all hoping that one of them or more of them will be more effective than aducanumab. So now let's talk about the behavioral and psychological symptoms of dementia, which is really, in so many ways, the most troubling part of dementia. So somebody who used to be so sweet and kind and gentle can really become agitated in a really alarming way, where they can become even sort of violent, hitting people. They can be yelling in the night. It can be a really, really serious problem for somebody who is probably suffering in a serious way when they're having these symptoms. The most important thing is to sort of go back to your checklist and make sure that they're not on a sedating medicine like zolpidem or anticholinergic like oxybutynin, which can, a sedating medicine can in an idiosyncratic way actually make symptoms like this worse, which is also why it's really, really important to have a lot of caution using a benzodiazepine in this case, where it might seem like a really sort of rational and effective sort of go-to medicine, because we use it a lot when people are suffering from really severe anxiety to help calm them down. And yet, there is definitely something about the brain chemistry of dementia such that benzodiazepines can have a really idiosyncratic reaction to make the symptoms of agitation worse. And so they're really not a recommended medicine to use at all for the agitation of dementia. And really the first, the second, and the third line treatment for symptoms like this are non-pharmacological approaches. So these are behavioral strategies that really have, a tremendous amount of data research has been done to show that they really do help. It can be complicated to implement a non-pharmacologic strategy like this. The most important book to recommend to families and other care partners is called The 36-Hour Day. The Alzheimer's Association also has good resources, a 24/7 helpline that people can call. There's a class called the Powerful Tools for Caregivers program that is a 6-week training for care partners to really help them to cope, to take care of themselves while they're taking care of somebody else. But really, one of the most important ways to approach somebody who's suffering from agitation is to shift how you communicate with that person. And so here are a few really simple tips on how to communicate with somebody with dementia. This is drawn from a handout, a one-page handout that you can download from our website, cognitionprimarycare.org. And that itself was adapted from a really, really important book that I often will recommend to families called Learning to Speak Alzheimer's. That is, was published almost 20 years ago, but is still a really, really approachable book that does go through a lot of this. And so some of the really key important tips are to really make sure that you're talking directly to the person with dementia, not about them as if they weren't there. And so people can fall into this trap where they're aware that somebody may not really be fully understanding what they're saying. And so then they may just start talking to the person next to them as if the person wasn't there. But the person may not understand the words that are said, but will pick up on the fact that they're being talked about, but without understanding what somebody is saying. And that really can cause distress and agitation. So really talking kindly directly to the person, even if they're not understanding everything that you're saying, they will appreciate the fact that you're respecting them by talking to them directly. If somebody does become agitated or aggressive, really helping families to focus on staying calm, that it can be such a natural reflex that if somebody comes at you with aggression, to sort of push back with kind of some forceful speech right back. And that it's a natural reaction that we all have, but that actually can escalate the agitation in a major way. And so encouraging families to don't be stern, maybe even withdraw, and an agitated moment will often pass, and whatever initially triggered the agitation might be quickly forgotten about. And so really encouraging families to stay calm is so important. And one of the ways that you can also really encourage less agitation is meeting somebody with dementia where they are. So somebody with dementia may often say something that isn't true, like, I'm just waiting for my husband to come home, even though their husband may have passed away years ago. And it can be really tempting to try to correct the person or remind them how what they just said is somewhat detached from reality. When you do that, though, you really do risk triggering somebody becoming more agitated. And so rather than correcting somebody to try to bring them back to reality, really ask them more questions about what they said, engage them in a related topic, maybe even change the subject. That really can result in less agitation over time. And again, this handout, which is a one-pager, is available on our website, cognitionprimarycare.org. And so there is where you'll find it. So our website has the training registration where you sign up for this training. And then the tab right next to that is a bunch of clinical tools, which are many one-page summaries of what we've covered in this series. And one of them is talking to somebody with dementia. But so what about antipsychotics? Because it's definitely true that sometimes somebody's agitation becomes so severe that it is really, they're becoming sort of almost a harm to themselves or others. They are becoming so agitated that it is reaching a crisis point where they may not be able to stay in the living situation where they are. And those non-pharmacological approaches should be tried, but sometimes they don't work. And so sometimes if people are having severe symptoms of agitation and other behavioral symptoms, and those non-pharmacological approaches are not working, then an antipsychotic is a totally reasonable thing to use. You just want to be aware that they are extremely sedating, that the main way that they probably work is by sedating people. And it's a concern. It's a concern to over sedate somebody. For that reason, you're going to want to start with a very, very low dose of one of these medications, like a much, much lower dose than you otherwise would see somebody on a medication like this for schizophrenia. And so teeny tiny doses that are best dosed as a once daily, every evening dose. Really avoid the impulse to use them as needed. You will sometimes get a request like, couldn't we give this medicine to somebody in an as needed way? The pitfall to that is that the medicine doesn't really kick in fast enough. It'll take 1 or 2 hours to start working. And often these symptoms are transient. And by the time that pill that you gave them starts working, they actually may be perfectly calm by then. And so rather than using it in an as needed way, much, much better to use it in a scheduled way when symptoms are severe, persistent, and repeated. And in that way, you want to use it in a scheduled every evening way, because symptoms like this are often worse at night. And you can titrate the dose up as needed every 3 days if that teeny tiny dose isn't doing it. But again, these medicines are so sedating that it is often the case that the teeny tiniest dose is going to be enough to really take the edge off of these severe symptoms. The other major pitfall with these medicines is that people get put on them and left on them forever. And the reason why that is not a good idea is that these behavioral agitation symptoms do eventually improve over time. And why is a little bit hard to say. It's probably the fact that their dementia is just becoming progressively worse, and that period of time when they were in more of a transitional stage with their progression was causing these agitated symptoms, that as they move out of that transitional stage and their cognitive impairment worsens, that they may actually just become calmer as a natural history of the disease. And so you may for sure be over sedating somebody sort of 3 or 6 or 12 months after one of these medicines were started. And so you want to not over sedate somebody. You want to give them maybe some of their cognition back by scheduling a taper to off of one of these medicines, say after 3 months. And if you take the medicine off and their agitation sort of ramps up and becomes very severe again, you can always restart it. And again, don't forget that incredibly important warning about Lewy body disease, that people with Lewy body disease can have a really severe idiosyncratic reaction to an antipsychotic and could cause severe irreversible Parkinsonism. And so it's not that a geriatric psychiatrist, you might sometimes see them trying an antipsychotic on somebody with Lewy body disease if other options haven't worked, but that is really because of that potential harm. It is really ideally a specialist level kind of management tool rather than a primary care tool. So what about other medications that are often used for these symptoms? So citalopram is one, trazodone is one, melatonin is one. The tricky thing is that there's not really great hard data that they work, and often there's a frustrating lack of effect, and they can cause side effects. And so you want to be, it's not at all wrong to try them. They are for sure less sedating than antipsychotics, and so it might be worth a try, especially if somebody is having less urgent agitation-like symptoms. And so absolutely should be in your toolkit. Now let's shift to talking about advanced care planning for dementia, which is really all about helping to align the medical care that people get with the medical care that they would have wanted. And your first thought would be like, well, what about a standard advanced directive. If somebody has filled out a standard advanced directive, doesn't that kind of take care of it? The problem is if you read the fine print of what is in almost every state's sort of official standard advanced directive, there's almost no wording in there that gives you guidance about dementia. They really focus on these extremely uncommon but hard and important situations when they come up. So if somebody's in a permanent coma or in a persistent vegetative state, that's the language that's in the state of Washington's standard advanced directive, or imminently about to die. But those are the main medical scenarios that are covered in a standard advanced directive, really giving almost no guidance about really the number one reason that people lose decision-making capacity, which is dementia. And so that's why I, together with Randy Curtis and the UW-Cambia Center for Palliative Care and Eric Larson, a longtime dementia expert, together developed a dementia-specific advanced directive that we tested and refined in primary care that is now available for anyone to download from a separate website, dementiadirective.org. And the way that that directive is structured is it gives a brief description of what mild dementia is often like, what moderate dementia is often like, and what severe dementia is often like. And under each of those descriptions, it gives people the same options to choose from of what they would want, their preference would be for goals of care at that stage. And really built into the directive is really providing the why of why somebody might choose something other than full care, which is that if somebody has dementia and then they have a catastrophic event like a cardiac arrest or severe pneumonia that requires them to be intubated in the ICU, even if they were to recover from an event like that, even if they were successfully resuscitated, because they went into that event with an already impaired brain, the odds that their brain would be significantly more impaired if they survived would be high. And that's a really solid reason why somebody might say, oh my goodness, if I had moderately severe dementia or even mild dementia, then I would not want CPR, I would not want intubation. And somebody might even choose that as a preference value, as a value for themselves, that they would want only comfort-focused care at one of these stages because of the high risk of adverse effects of agitation, more complications from many interventions. People can have a really hard time going to the hospital for life-prolonging care if they have even mild dementia. And somebody might have a very clear preference that, gee, that is not my value, that is not what I would want. And this dementia-specific advanced directive gives them an opportunity, a structured way to communicate that to their loved ones. And so this is the website where you can download that directive. Again, this is separate from the Cognition primary care website. This is the dementiadirective.org website where anybody can download this form for free. And so an interesting experience that I had as I was testing this in primary care is at first I was giving it to people who had mild cognitive impairment, thinking that that would be the most important time to give somebody a directive like this. The interesting experience I had is that it is actually very difficult for many people with mild cognitive impairment to imagine and plan for the future. And so even though people seemed really grateful and appreciative when I offered it to them, I actually got very, very few of them back from people with mild cognitive impairment. So instead, I started offering it to all of my patients as part of their Medicare Annual Wellness Visit over age 65. And instead of getting hardly any of them back, I started getting almost all of them back, because this really is something that many people do have strong feelings about and are really happy to have a structured way to communicate them. And so really, I would say that the best time to offer somebody a dementia directive is before signs of cognitive impairment occur. But so what about our patient that we are following along, who now has early dementia, or even when she had mild cognitive impairment? The most important form for somebody at that stage is really setting their durable power of attorney for healthcare. So who will their proxy decision maker be? And on one hand, it's not that important of a form for all of our patients to have, because generally the people who are set up as the default under Washington state law align very care closely with the people who they would want. And so it's just not that big of a deal for all of our patients to have this. It's not wrong to offer it and encourage it, but it's just not that practically an important thing. But for somebody who has early cognitive impairment, it's actually extremely important for them to fill this form out, because we really want to know who are the alternates to their default person. So usually their default surrogate decision maker is going to be their spouse, but in somebody who is developing early stages of Alzheimer's disease, this is a 10 to 15 year progression, and it's very possible that 5, 10, 15 years down the line, we're going to want to know who is that person's durable power of attorney, who is their surrogate decision maker. Their default sort of spouse may no longer be available to serve in that capacity. And so knowing who the backup to that person might be, who might be their best friend, it might be their neighbor, it might be, one out of their 5 children. And so really, this is an incredibly important document to offer as part of advanced care planning for people with mild cognitive impairment. The next most important document that is so important for advanced care planning, especially for somebody with dementia, is the PULSE form. And so the state of Washington came out with a new version of the PULSE form 2 years ago. I think in a good way, they changed the meaning of the acronym. So the acronym is still POLST, but the P no longer stands for physician order for life-sustaining treatment. It's now portable order for life-sustaining treatment, which acknowledges that people other than physicians, nurse practitioners, physician assistants can sign this document. And this is just such a crucial tool to anchor your goals of care conversation. So you have this conversation generally with a family, the surrogate decision maker, and this is filling out the PULSE form is an absolutely invaluable way to communicate what the outcome of that conversation was across the different sites that somebody might be living in. And it sets the goals of care now. So what if their heart stops now, or they can't breathe on their own now? Is the preference for comfort-focused care? Is the preference for intubation and in the ICU? We would hope not for most people with dementia, and really having this conversation and filling out a PULSE form is an incredibly powerful communication tool to make that communication portable across the settings where they might go. And these are really very similar why value statements to why somebody might choose something other than full resuscitation in the dementia directive. Similar reasons that why somebody might choose other options on a PULSE form. Somebody might say, gee, I don't think my loved one would want CPR or intubation, because even if they were to survive such a catastrophic event like that, they might be in a much worsened state than they were going in. And again, the comfort-focused care is such a reasonable goal of care for somebody, especially with moderate to severe dementia, who may have many years to live. So they are probably pretty far from for qualifying for hospice care, but it may be perfectly reasonable and appropriate to have their goals of care be comfort-focused care, similar to somebody on hospice, because of the high risk of adverse effects of agitation and more complications from life-prolonging care. And the phrase that I use most often in conversations with family members about this is, imagine if your loved one could look on themselves now. What do you think that they would say for themselves? And this is also a situation where if somebody happened to have filled out a dementia directive before they developed cognitive impairment, that can be a really useful tool to help to bring their voice into that conversation. And so I want to take a moment to just talk about the Medicare Annual Wellness Visit, which is really still a valuable, useful tool, a visit for patients with dementia, where on one hand, we might think of like, gee, do we really still need to be doing that, since a lot of most annual wellness visits are spent on preventive care, like cancer screening, which we are generally going to be moving away from as people develop progressive dementia. But you can actually use that time in an annual wellness visit to talk about advanced care planning. And such an important practice tip is that you can use an easy-to-add billing code for advanced care planning to an annual wellness visit code, and you can actually double the RVUs that you get for that visit with no extra cost to the patient. The documentation for using that code is actually very, very simple. It's not one of these Medicare codes that has, paragraphs of additional stuff that you have to do. It's really they're really paying you to have a conversation. And so if you are spending more than 15 minutes discussing advanced care planning at an annual wellness visit, such as discussing a dementia directive for somebody before they develop cognitive impairment, or talking to a family member or a patient with mild cognitive impairment, or filling out a pulse form, that is really all you need to do is say that you spent more than 15 minutes talking about that in 1 or 2 sentences. It increases the RVU for the visit from 1.5 to 3.0. And again, there's no additional cost sharing for the patient if it is an annual wellness visit. Documentation is very simple wording, and we have a one-pager that goes through what codes to use and how to add the code in especially the UW version of EPIC on our website, cognitionprimarycare.org. And there it is. Again, it's under the clinical tools tab. So under the follow-up section, you'll see both the talking to someone with dementia handout, as well as the billing for advanced care planning handout. So let's go back to our case, the 82-year-old woman whose diagnosis is now early dementia. And at an annual wellness visit, you spend 20 minutes discussing advanced care planning, really focusing on a durable power of attorney form. So who is the alternate decision maker to her husband? And really, you can absolutely have a meaningful conversation with somebody about, if you were to survive a cardiac arrest, I worry that you'd be much worse off now. And so, my experience is that many people in your situation might not want CPR in that situation, and you can explore where they are with that. And again, in a similar way that I talked about before, often somebody with mild cognitive impairment will have difficulty really kind of like making that planning type statement. And so in that situation, you may be talking to the surrogate decision maker at that point. And again, even if the surrogate decision maker is the person who is their default, filling that form out now, because somebody very well might be able to say who their alternate would be, even if they have trouble expressing a wish for what their code status would be. It is actually they are still have capacity and will still be able to say who they would sort of trust the most to make medical decisions for them as a second to their usual default. It's very easy to document, it's easy to bill, and this is better, higher quality care when we have these advanced care planning discussions and can align the care that people get much more closely with the care that they would have wanted. So takeaways from today are that tenepezil and memantine are easy to use, so it is absolutely reasonable to offer them, but do keep in mind that they generally have small benefit and not really effective for mild cognitive impairment. For behavioral psychological symptoms, keep in mind that people really should be tried first, second, third line with non-pharmacological approaches. Use antipsychotics only when symptoms are really severe and non-pharmacological approaches fail. Remember that if somebody has Lewy body disease, that they can have really severe reactions to antipsychotics, and really try not to use antipsychotics in an as-needed way. Schedule them, titrate them every 3 days, and make sure that you put a time in the future where you're going to try a taper to off. In terms of advanced care planning, takeaways, dementia directive is really useful to offer to everyone over age 65 before they develop cognitive impairment. You can use an advanced care planning code as part of the annual wellness visit to have those conversations. For mild dementia, it's so important to fill out a durable power of attorney for healthcare proxy document with alternates as soon as possible while somebody still has capacity to identify who those alternates would be. For moderate to severe dementia, the pulse form is appropriate and valuable. And the really key useful phrase is, imagine if your loved one could look on themselves now, what might they say they would want? And remember that the annual wellness visit is useful not just for advanced care planning, but actually also a way to track their activities of daily living, because that's in the annual wellness visit questionnaire. And you can use that annual wellness visit to also talk about advanced care planning. All right, so that is the end of part 3, which is actually the end of the series. It's been such a pleasure to have you with us throughout all 3 parts. And don't forget to go to our website, cognitionprimarycare.org, where you can download summary tools that we've been talking about. And now we have time for questions, and I'll let Jackie start with any that have come in through the chat.
Yeah.